Respected Chairperson and learned audience, very good evening. My title is Preparation is Everything is for Success. I'm not talking about the exam preparation, talking about the preparation of calcium bed. Like to ask a question. Coronary calcification is associated with impaired stand delivery, stand under expansion, stand malposition, age dissection. I think the answer is all of above. So adequate evaluation of lesion by imaging like IVUS OCT and adequate lesion preparation through calcium modification is crucial in ensuring procedural success and reducing adverse cardiovascular outcome. And there are several tools in our hand like NC balloon, angiosculpt, cutting balloon, orbital atherectomy or rotational atherectomy, and nowadays IVL and C-SOPIAN balloon for modification of calcium bed. And this is a very common algorithm while we follow usually while treating a calcified lesions. Like if the calcium is nodular, then the orbital atherectomy or rotational atherectomy is an option. If it is superficial, mild to moderate calcium, then we could manage with NC balloon, cutting balloon, or scoring balloon. But if it is moderate to severe calcium, if the lesion is balloon crossable, then we can seek option for IVL. And if it is not balloon uncrossable, then again the rotational atherectomy and orbital atherectomy, which one is available, is our option. My first case is a 63-year-old gentleman presented with chest pain. Patient had previous history of CCS3 angina. Patient was hypertensive smoker. On admission, patient had ischemic change in anterior lead, and echo finding is inferior wall is thin echogenic akinetic, anteroseptal wall is hypokinetic, and ejection fractions 43%, and tropi was elevated. So we are dealing with a case of non-STMI. Initially patient was stable, but later on patient developed ongoing chest pain and some sort of hemodynamically unstable. So we quickly moved the patient to cath lab, and the CAG, and the CAG finding is there is a very tight lesion in LAD, and there you can also appreciate a term track calcium even in the angiogram, and also tight lesion in LCX, and RC is 100% occluded. As the patient have ongoing chest pain, so we decided to do PCI of LAD and LCX to this patient. And we hook EBO guide catheter to the left system and dilate the LAD lesion with 1.5 balloon, but we could not further negotiate a higher diameter of balloon throughout the lesion. Then we, at this stage, patient get some relief from the chest pain and some sort of hemodynamically stability show. So we go for IVUS, and you appreciate there is a almost 360-degree calcium arc in the lesion, and the calcium is thick. There is almost no reverberation, acoustic shadowing just behind the calcium. This all the IVUS evidence of thick calcium. And there is also osteal lesion that was underappreciated in angiogram in LAD. So with this IVUS, we decided to treat the lesion with rota and put the stent covering the LAD ostium. But the patient also had LCX disease, and at that time the rota instantly not ready in our cath lab, so we quickly switched to fix our LCX lesion with 2.5 into 34 millimeter stent. Then again come back to LAD, and rota was done with 1.5 rota bar and 160 RMP. And this is a picture after rota, and you appreciate there is a crack in the calcium and there is a new generation of reverberation, all at the sign of successful rota ablation. And after that, we fix the lesion with 2.5 stent covering the LAD ostium, and further post-dilatation was done with 3 into 15 millimeter balloon, and after the procedure, the EKG change comes down to normal. My second case is a 58-year-old gentleman presented with chest pain on mild exertion, having CCS3 angina. Patient was hemodynamically stable, but patient have very tight lesions in LAD, ostium, and I was showing again very heavy calcium around more than 270-degree arc. So in this case, as it is balloon crossable, we decided to go for IVL in this lesion as the calcium is very thick. We took 2.5 IVL into 12 millimeter IVL balloon, and after several shock with IVL to the lesion, this is IVUS after IVL. And you appreciate, I will work with creating micro crack in the calcium and weakening the calcium. So after preparing the lesion with IVL, we deployed a stent 3.5 covering the left main ostium also and also the LAD. And this is the final result. My take-home message is coronary artery calcification continues to increase in prevalence in parallel with an aging patient. PCI of calcified coronary artery lesion remains a persistent challenge in contemporary interventional practice. Growing use of intravascular imaging to inform a strategic treatment algorithm is providing critical to optimal patient management. Newer device technologies increasingly facilitate more complete and effective revascularization with superior short-term procedural result as well as long-term patient outcome. In our case, use of IVUS for evaluation of lesion and rotablation and IVL made our life in cath lab easier in decision making as well as treating the patient. Thank you so much for your patience hearing.